this computer. All right. So the first thing that we're going to talk about is vital signs. And I have a reputation for speaking very quickly. It's sort of cultural for me to talk very fast. So if I start to do that, just raise your hand and tell me to slow down. I'm going to try to slow down on my own. So let's just talk a little bit about best practices for vital signs. This might seem like a very simple skill, but in my mind, because of the role that nurses have, where we are the ones who are with the patients all the time, physicians come in and they have their expertise, but in my practice, the nurses are the ones who are with patients all the time. And so we notice these subtle changes. We notice when something used to be one way and now it's the other way, which is often an early sign that a disease has progressed or there's a complication that's developing. And so it's really important that we notice these subtle changes so that we can report and intervene. So what is the purpose of vital signs? So we want to establish a baseline for future assessments. I'm always saying that just the value itself of a blood pressure isn't as valuable as comparing it to the blood pressure yesterday or looking at the blood pressure the next day, because everyone has their own sort of normal range. So we want to make sure that we get vital signs right away so that we can establish what a normal range is. It helps us to be able to understand and interpret values. That's one of the things that I was saying about the comparison. Appropriately delegate the measurement. So who can take vital signs? Who do we communicate these findings to? Do we need to tell a charge nurse? Do we need to tell the physician? Once we have these values, do we need to document it in, the chart? Where do we put this information once we have it? We want to make sure that the equipment is in working order. So it's, great to take a blood pressure or to take a temperature, but if your equipment is not working properly, then you're not getting a correct value. So you want to, periodically look at the equipment and make sure that the equipment is working. And accurately document the findings. We had someone recently that arrived to the floor with once we took the temperature, it was like 93 Fahrenheit, or what would be probably like 33 Celsius, which is very low. And the prior nurse had documented just 5 minutes before that the temperature was 37 degrees Celsius, which is a total normal value. Now, I don't want to accuse anyone, but that was probably an inaccurate piece of documentation, because it's very unlikely that the patient went from 37 to 32 in just the time of the transport. So it's really important that we document the correct number, whatever we find. So let's see. Okay. So we'll go right in. So temperature is the first vital sign that we'll talk about. So what is body temperature a measure of? It's a measure of heat produced and heat lost. So one of the major regulators for temperature is your skin. Your skin is what, allows your body to stay one sort of level temperature. For ranges, you probably use Celsius. So 36 to 38 degrees Celsius is considered a normal value. That would be the absence of a disease state or the absence of a complication. This is where your body likes to be. This is where oxygen transport and circulation and, immune system all works at an optimum level when this is where your body temperature sits, between this 36 and 38 degrees Celsius. How am I doing with talking? Am I fast or a good pace? Okay, I'll keep going. So what are the temperature sites? So we can get a temperature orally, rectally, axillary, under the armpit. You can do the tympanic membrane. You can see that here, this forehead, temporal artery, esophageal. Oftentimes, if somebody has like a breathing tube in, then we can put in an esophageal probe. Certainly, we wouldn't do that on someone who is awake and doesn't have a breathing tube. That wouldn't be very nice. And pulmonary artery temperature. Again, if someone has an invasive line that's going into their heart, then we can have an internal temperature that way. the most common sites that you probably see here are the mouth, the armpit, the ear, or rectally is where you're most likely get your temperature. So again, we're talking about what normothermia is. So hypothermia. So what are some of the reasons that someone's temperature is low? Does anyone, I mean, they're here, but does anyone have any ideas about why someone would have a low temperature? So infection, believe it or not, we often think of infection as having a high temperature, but certainly when someone has an infection, they can also have a low temperature. You see this often in folks that are older than 65. Their immune system sometimes works a little bit differently, or folks that have cancer or in chemotherapy where their immune system just works differently. So maybe they don't have like the metabolic rate to be able to generate a higher temperature, but their body can try to kill the bacteria by having a lower temperature. Exposure. I think you guys are in a climate where it's warmer. I'm in a climate right now where in the wintertime, it can get below, it can be like negative degrees where it's like freezing. You go outside and your eyelashes freeze. So it's maybe unlikely that this would happen in your region, but certainly here in the Northeast of North America, if you were left outside for a long time in January, then you could certainly get exposure and have hypothermia. Cancer, like I talked about, and then brain injury. Your skin is one of the major organs that regulates temperature, and your brain is probably the second. Your hypothalamus really, regulates a lot of your body, your heart rate and your respiratory rate, and also your temperature. So if there is an injury to the brain, we often find that the brain has a hard time regulating that temperature, and you have these really large swings. Hyperthermia, you'll see that a lot of this is similar. So infection, brain injury, heat stroke. So this is something that you may see in your region, that if people are outside working for a long time or, don't have access to water, that they can get heat stroke if they're outside too long, which can cause hyperthermia. And then there are some drugs that will artificially elevate the temperature. So if you have a patient that has one of these readings, you'd want to, tell the physician, you want to make sure that you document it correctly. And then in your nurse brain, you might start to think, what is the most likely cause of this? If you have someone with a terrible cough, then you're like, oh, it's probably infection. If you have somebody that was like working outside all day, you're like, oh, maybe this is a heat stroke. If you have someone that, recently was in a car accident and had a head strike, then you're like, maybe this is related to their brain. So the next thing we're going to talk about is heart rate. So this is an indicator of the circulatory status. So the electrical impulses originate from the SA node, and the SA node in your heart is what is like your pacemaker, or it's like the thing that sets the tempo of the, like if it was of the drums. So a normal heart rate ranges between 60 and 100 beats per minute. And that is, again, optimal status. That is where, when your heart rate's between 60 and 100, that's where your metabolism likes it, your cells like it. It's the best time for oxygenation of the tissues and through the lungs. This is where your heart is sort of happiest, and this is where the rest of your body works its best. So what are the different pulse sites that we can use? There's many different pulse sites. The apical pulse, how many of you have taken an apical pulse? Raise your hand. So when you take your pulses, do you just use your fingers? Do you like palpate on the wrist, or do you use a stethoscope? Use a stethoscope. And where do you usually, which site do you use to listen to the heart rate? Do you listen directly to the heart, or do you listen to like the femoral pulse or the radial pulse? Do you usually radial? Okay, great. I think it's a good practice to get into, at least the first time, to put your stethoscope. It's the mid-clavicular line. If you look at the clavicle of somebody, in the middle of that and go down 4 spaces, that is where your heart is closest to the skin. And so if you put your stethoscope right in that place, you're hearing the heart at its loudest. So at least the first time when you're taking a heart rate, it's really interesting. I challenge you to do this in your practice, to listen to the heart rate at that point, and count it from there. What I think is a nice thing to do also is, while you're listening to the heart right there at that point, to also feel with your two fingers the radial pulse and see if they're the same, see if there's any differences, because sometimes when there's an arrhythmia, will be different what you hear at the base of the heart than what you feel in the wrist. So that might be an activity that you guys can do, and maybe you can tell me next week if what you discovered. But there's many pulses that we can take. Often if we're coding somebody or there's an emergency, we take a carotid pulse or a femoral pulse. These are places where the vessel is very large, and so it should be really easy to feel a pulse. So if somebody's in dire straits and we think that they don't have a heart rate, because the radial pulse is smaller, we may not feel it. So it's good to try the carotid or the femoral pulse there, just because it's such a large vessel. So bradycardia is when the heart rate is less than 60. So remember, we said optimal is 60 to 100. That's where your body is the happiest. Bradycardia, what can cause that? So it can be just a cardiac arrhythmia. So we said that the SA node is what is setting the pace of the heart at 60 to 100. So if there's something wrong with that SA node, there is a backup. And the backup is an AV node, which just paces the heart, but does it at a lower rate. So if you are in, there's something wrong with your SA node and your AV node has taken over as the backup pacemaker, then you might have a lower heart rate. That might be an indication. The other thing is athletes, or when someone's sleeping. So I went to the dentist yesterday and they took my blood pressure and my heart rate, and I was actually pleased to see that my heart rate was at 55. I've been doing a lot more exercise recently, and so I'm glad that my heart is maybe a little bit more efficient. And so I had a resting heart rate of 55. So oftentimes you'll see people that are runners or people that are very active have a heart rate that's lower, like sometimes between 40 and 60. And this is normal for them because your heart is so efficient. It's able to pump out enough blood with each beat that it doesn't need to beat as fast. So you don't need to really be worried if somebody's heart rate is less than 60. You can sort of think about it and say, is this person really young? Is this person really fit? Or are they asleep? That's the other thing, is sometimes when you're asleep, your body really relaxes and slows down. And so your heart rate goes less. So this we worry about a little less. Now, if the heart rate is below 40, even if they're fit, even if they're sleeping, we still want to notify someone and say, what's going on here? The other thing that we want to look at is comparing it. So if yesterday this person's heart rate was in the 70s and 80s all day, and now today it is 45, that's a pretty big change. So this is where it goes back to best practices in vital signs, that comparing the person to the person is really helpful. So tachycardia, what are some of the things that can cause tachycardia? So when it's a normal rhythm in tachycardia is often what we say is compensatory. It's normal. It's a normal reaction to an abnormal stimuli. So it's not something that we necessarily want to change the heart rate. What we want to do is figure out why is it happening and treat that. So when someone is in pain, oftentimes their blood pressure and their heart rate elevate. If there is an infection, then oftentimes your heart rate elevates. And what I mean by compensatory is that your body has identified there's something wrong, and your heart has responded by pumping out more oxygenated blood to the tissues so that your body can perform the processes that it needs to fix whatever is wrong. So if someone is infected, your heart is beating faster because it assumes that your body needs more white blood cells to fight this infection. It needs more oxygen to be able to make energy. Now, if someone's bleeding, then oftentimes the blood pressure will drop. And so the heart rate will get higher to make sure that there's enough blood pumping out to the tissues. Similarly, if there is a fever, that is a metabolic response that requires energy. And so your heart will beat really fast to be able to support your body making that temperature rise. Hypotension for any reason. Hypotension is that drop in blood pressure. So that can happen from dehydration. It can happen from infection. It can happen from bleeding. So when your blood pressure drops, your heart rate usually will go up. And this again is a way that your heart is compensating or trying to make sure that your body has all the blood that it needs. And finally, if it's an arrhythmia, that's something different. So a lot of times here we see like atrial fibrillation or atrial flutter, and that is an arrhythmia. So that is something that is not compensatory. It's not the heart fixing something. It's that the heart itself is the problem. And so that requires more expert guidance. If you have doctors that work in cardiology, you might want to talk to one of them. Any questions about heart rate? No? Okay. So respiratory rate. So this is assessing a full inspiration and expiration. I think in our practice, I think people get sort of, they just often throw in the number 18. They're like, they barely count the respirations. They're like, no, it's 18. You see 18 an awful lot. But a normal adult breathes between 12 and 20 breaths per minute. And at least on the first time, I think it's important to assess for a full minute, because sometimes you'll have people that breathe really fast, followed by really slow. You'll see like an irregular breathing pattern. So at least in your first assessment, I think it's a great idea to listen for that full minute, watch, observe for that full minute, and count the respirations in that minute. It can really vary with age and disease state.
I will jump in here and just mention I'm a pediatric nurse, and I'm telling you, those newborn babies, the respirations, you have your eyes on their chest and you're counting at a much faster pace than you are with an adult. And it's really important in pediatrics, particularly in the newborns, to get a very accurate reading, because they can't share with us, you know, their subjective experience. So we have to look for objective findings in order to really make our assessments. So throw in the pediatrics there.
Yeah, that's really important. I remember in nursing school having to count pediatric respirations, and it was like a skill, because it's so fast that it's so much different than counting adult respirations. It's true. I have a trick when I'm counting respirations, is that I do it right after I listen to the heart rate, because I find that if someone knows that you're counting their breathing, that they sort of breathe irregularly, either faster or slower. And so I leave the stethoscope on the point of the heart. And so they think I'm still listening to the heart, but I'm actually counting the respirations, just as a sort of distraction. Because otherwise I've found if they know that I'm counting, then they're like, don't breathe for a moment. So when someone's breathing less than 12, which is what we've said is normal, what are some of the reasons? So unfortunately, here in the Northeast, in a lot of the United States, we have a real opiate epidemic. And certainly the hospital that I work at, Boston Medical Center, is what we call a safety net hospital. So we do have quite a bit of people with substance use disorder. I don't know what that's like in your region if you have that, but we have a lot of people that are addicted to opiates. And so oftentimes when we discover people that have a respiratory rate that's less than 12, it's from some sort of drug overdose. And so we have an anecdote that we can give to block that drug and allow that person to breathe again. This can even happen in your clinical practice when you're medicating someone. If someone's had surgery and they had anesthesia, or they had a procedure and they had pain medication, certainly a lot of sedative medications, pain medications have respiratory depression as one of their side effects. So, even if you don't have an opioid epidemic like we do here, over sedation or, receiving too much of a drug is certainly one of the things that can cause a decrease in respiratory rates. So that's something that you want to look at. Tachypnea or hyperventilation, people that their respiratory rate is greater than 20. This is certainly something to alert the physician about, talk to your nurse peers about, to figure out sort of what's going wrong. So pain is one of the reasons. I didn't put anxiety, but anxiety is too, you know, or fear is another reason that somebody might hyperventilate. Hypoxia. So when there is decreased oxygen in the blood, this is another way that your body will compensate. In addition to tachycardia, your body will start to breathe really fast in order to get more oxygen into the blood and then ultimately to the tissues. And then fever is another way, and it's sort of the opposite. It's like your body is trying to blow off some of that, you know, extra carbon dioxide that's, you know, being generated because of the metabolic processes that are happening. Cheyne-Stokes breathing. Has anyone ever heard of Cheyne-Stokes breathing? So when somebody is sort of towards the end of their life, that oftentimes they have an irregular breathing pattern. And this is one of the ways that we know someone is transitioning into, you know, the end of their life, into ceasing respirations. So it's cycles of really loud, deep breaths, followed by periods of shallow breath, and then no breathing at all for like a prolonged time. And it's almost like you'll think the person has stopped breathing, and then they'll take a, you know, another really large, deep breath. So this is often observed at the end of life. So blood pressure. So what is blood pressure a measure of? Blood pressure is a measure of the force exerted on the artery walls. When I talk to my students about blood pressure, I often, do you have hoses that you use to like water your garden or water crops or anything? So I try to think of something that, you know, is where fluid is going through a large tube. And here I talk about a garden hose. So it's that force of the blood on the artery walls is really what we're measuring in blood pressure. We look at the systolic and the diastolic, which is just the different phases of the lub-dub, or when the heart is beating. And we need a certain blood pressure to perfuse the organs. If you think about it, the organs are a solid mass. And so in order to have fluid be able to infiltrate that solid mass, we need a certain level of pressure to get that fluid in all the spaces of the vasculature of that mass. So we want to make sure that here we say MAP, which is mean arterial pressure. And we say that we like a MAP greater than 60. You might also say that, that we need the systolic blood pressure greater than 100. And this is just to say that we need a certain force to make sure that that blood goes all the way into the kidneys, or to make sure that blood goes all the way into the intestinal tract, or all the way into the liver for the toxins to be filtered, that we really need a certain amount of pressure to get that fluid into the organs so they can do their jobs. So what are some of the things that affect blood pressure? Blood pressure is also really, you're looking at cardiac output, or how much blood is coming out of the heart. And so one of the things that affects that is peripheral vascular resistance. So when your heart is pumping out into the arteries, how open or closed are those arteries, right? If they're really open, then that's really easy for the blood to go through them. If they're really closed or constricted, then it's much tougher for the blood to get pumped out there. The other thing is blood volume. How much blood is in the system? How much blood is in the vasculature? So some of the things that we've talked about that can affect that: bleeding, certainly, dehydration. If the person is overloaded, then it can be if the heart isn't working properly. And this is where heart contractility comes into play. So the heart is a muscle. So much like you make a muscle, like you make your bicep muscle, your heart is a muscle as well. And so if your heart muscle is weak and not able to pump very much, then that is also going to cause a drop in your blood pressure. Vice versa, if you're very young and fit and you have a really strong muscle, then your heart is going to be able to pump really efficiently. So these are blood pressure ratings. So we're really looking at systolic blood pressure here. So a hypertensive crisis is when you're 180 plus. This is and this is systolic, diastolic. Hypertension, if your systolic is greater than 140, you're starting to worry about hypertension when it's 130 to 139. You really like the blood pressure between 90 and 120 for your systolic blood pressure. This is considered a little elevated as well, between 120 and 130. This is another area where it's really important to know the baseline of the patient. For instance, someone who's in renal failure, a lot of times lives in a blood pressure in the 140s. So what I find in clinical practice is if somebody, is a dialysis patient or has chronic renal failure and they come into the hospital, they have a blood pressure of 140 and we try to get it down into this normal range, they're not working optimally. That is what their body has sort of calibrated to. And so they need that pressure. They need that increased pressure in order to be able to get blood into the organs. Versus there are also some folks that live lower. I'm somebody that has a lower blood pressure. It's not uncommon for my blood pressure, my systolic, to be in the 100s. So if somebody was like, oh no, her, blood pressure is low, we need to pump her with fluids, that wouldn't be true. So that's why it's so important to have a baseline of these vital signs. So what are some of the things we kind of talked about? This hypotension, dehydration, bleeding, certainly sedative drugs, and then just the size of the cuff. This goes back to best practices at the beginning. Was the blood pressure cuff the right size? If it's too small, you're maybe going to get a false high. If it's too large, then you could potentially get a false low. Hypertension, pain, anxiety, some sort of underlying disease. We talked about this. It could either be a disease of the vasculature or it could be a disease of the kidneys. The kidneys and the heart work really well together to sort of regulate blood pressure. Volume overload. Does the person have too much fluid? That can be that they're not making urine, or it can be that they were, over given fluids in the hospital, or that they, over drank something, or that their sodium is off. And then again, a small cuff is another thing that can maybe cause a blood pressure to be high.
So Nicole, can I ask you a little bit about the cuffs? Because
Sure.
in pediatrics, we had different size cuffs for different ages.
Mm-hmm.
In fact, and I know in adults, especially, when I worked with some of the adolescents who were larger, taller, larger, I always had to measure that cuff to make sure it was the right fit. Do you have any easy ways to think about best fit for a cuff?
There probably is a best practice, and I actually don't know it. I know that we sort of eye things.
Yeah.
Yeah, that there's like for adults, there is like small, medium, and large. And so sometimes it's like sometimes it's like trial and error,
Yeah.
and just like visualizing. And some people surprise you where you think that person would be a small, but then for whatever reason, whether they're muscular or whatever, they have a larger bicep than you would think. So that's a great question. I'm sure there is a best practice I should add into this slide.
Yeah, we should find that out and get back to you next week, because I do think there is an arm width, and width of the cuff for the upper arm,
Yeah.
and I think it should be measured. If you have a question about whether or not it's the right size cuff,
Yeah.
we'll get you the details on.
Do you have a practice? They may have a practice already. Do you have a practice for measuring your blood pressure cuff? No.
No?
No.
No? Okay. We'll see if we can find the actual formula for how to get the best fit. I would like to review it too myself.
Yeah. Okay, so this is a post test. So the first question is, you have a patient who has a significant elevation in blood pressure measurements from one day to the next. What could be the reason for this? Would it be a decrease in cuff size, an increase in cuff size, new onset pain or anxiety, or both A and C? Very good. You're very smart. Got that right away. Okay. Which patient would be most likely to present with a pulse rate that is lower than normal? A 70-year-old telephone salesman presenting with dehydration, a 20-year-old runner who had surgery 4 days ago for a fractured leg, a 67-year-old who presented with an exacerbation of COPD. So who would be more at risk for bradycardia, a lower heart rate?
Mine is A. No, B.
I heard
B, a 20-year-old runner who had a surgery.
excellent. Yeah, 2 risk factors. Yep, very good. Yep, he's young and he's fit, so he probably has a resting heart rate that's lower than 60. Excellent. What are the 4 main vital signs? Very good. Yep, blood pressure, respiration, temperature, and pulse. B. Yes, very good. We didn't talk about oxygen saturation, which do you do oxygen saturation? Do you have probes that you measure?
Yeah, we do.
You do, okay. Yeah, we do too, but we don't consider it one of the vital signs, although we often take it with the vital sign. Great. In a tachycardic patient, the heart rate is said to be, so what do we say tachycardia is?
C.
D, right, exactly. D, yes. So remember, bradycardia, yeah, is less than 60, and tachycardia is greater than 100. Very good. Okay, heart rate. What is heart rate a measure of? Is it a number of breaths? A, very good. Yep, that one was pretty easy. A. Where can we find the radial artery? We said this is, you said this is where you
Yeah. Lateral side of the forearm.
very good. Excellent. You guys are stars. Respiratory rate is number of lobes in the lungs, the number of breaths in and out per minute, the number of breaths in per minute, or the number of breaths out per minute.
The number of in and out. Yeah.
In and out. Very good. Yes. Yes. Very good. Yeah. You want to make sure you measure inspiration and expiration. Excellent. What do we call a slow pulse rate or a pulse rate less than 60? Yeah. I made this word up, rapidicardia. You like that one? Okay. And that was it for that. Thank you. Any questions about vital signs? Otherwise, we'll go on to pain. I have a short one on pain.
Do you all need a break or are you good? Everyone okay? We'll keep going then. All right, terrific.
All right, great. So we're going to talk a little bit about pain management, and then I have a short case.
Yeah. Hello.
Hello.
Yeah, before we come to pain management, I just want to make a contribution with regards to the vital signs we have gone through.
I'm sorry, say it again.
I said before we go to pain management, I want to make a contribution on the vital signs.
Okay.
Great.
Yeah, so sometimes an increase in respiratory rate or the heart rate could not be a direct medical response. It can be altered by several factors, like elimination of the pain, like when somebody is in anxiety, somebody that have just done a physical exercise like running or playing football, that can increase the respiratory rate or the heart rate as well.
Very good. Yeah, that's true. I didn't mention that. You're absolutely right. Yeah, that's a great point. Yes.
Thank you.
Thank you. Thank you. I love the collaboration. It's always important. Okay, so pain management we'll go into a little bit.
And you know, we can add those comments to the slides for the next presentation. So really, we can work together to enhance all of our knowledge.
Absolutely. Yes. Sometimes I have a blind spot for things from working in the hospital versus what you might see in like a community center. You know, it's like not often that we have folks that come in that have like recently exercised. So that's such an important point that should be added. So thank you for that. And any other comments or things that, you know, you think should be added, we're happy to add in. So what is pain? So pain is the peripheral nerve fibers that are found in the skin, the joints, the viscera, the bone, muscles. They send a message to the brain signaling pain. So it's basically a stimuli happens in the exterior or in one of the organs, and it sends a message to the brain saying that something's wrong. This is just a little visual of the peripheral nervous system. Look how intricate that is, that there are nerves everywhere. You know, there's nerves in your brain, in the tips of your fingers, you know, inside your body. There's nerves in your internal organs that you can't even see. So I just think this is a nice visual of sort of how intricate the nervous system, the peripheral nervous system really is. I like to think of pain as your body's emergency alert system. I think sometimes in North America, we've gotten into this not great habit of when someone's in pain, immediately wanting to mask that pain, right? Immediately wanting to give them something to fix the pain. But I think our body is very smart and very intuitive. And so if there is a stimuli in the peripheral system, in the peripheral nervous system that is signaling pain, it's basically our brain telling us that something's wrong. You know, if you have your hand on a hot stove, you're going to feel pain to tell you to take your hand off that hot stove. You know, if you have, you know, a cut or a penetrating injury from something, you will feel pain because your body is saying, hey, take that out. Similarly, if there's like a tumor growing in an organ, then and you feel pain there, it's your body saying, hey, we need to know there's something foreign in our body that shouldn't be there. So I really like to stress that, yes, it's important to treat pain, but it's also really important to look at why is the person in pain? What is the body trying to tell us? So pain happens when it can be thermal, like I said, you know, from a burn, it can be mechanical, it can be a chemical stimuli, reach a nauseous intensity, then it suggests that there's an injury, and it becomes detected by that peripheral nervous system that we just looked at, and it sends a message to the brain saying, hey, there's something wrong. So some of the complications of, we will look at like acute pain versus chronic pain. So when somebody has chronic pain that isn't treated, it can lead to depression and anxiety and a decreased quality in life. So we see this often in folks that are older, you know, just getting older, your bones start to hurt more. You know, you may have accumulated injuries throughout your life. Or someone who has had a significant injury in their life that they never really fully recovered from, then they often can have chronic pain that can lead to sort of a withdrawal from life. Versus acute pain, somebody who's had surgery or who's had a recent injury, the complications that we worry about are decreased mobility. We worry about shallow breathing, which can lead to pneumonia. And we worry about an increased blood pressure and heart rate, which can have negative effects if not treated long-term. Your heart can basically tire out. So those are some of the complications of pain. The reason why we don't want to let pain just linger, you know, as much as we don't want to just mask it and not investigate what's causing it. We also don't want to just say, you know, oh, toughen up, deal with that pain. You know, we want to make sure that we make the person more comfortable to prevent some of these complications. So what are some of the signs and symptoms? So here we are with our vital signs, respiratory rate greater than 20, tachycardia, heart rate greater than 100, hypertension, higher than baseline. For me, like I said, my blood pressure is usually about 100/70. So for me to have a blood pressure that was, say, 125 over 80, as much as that looks normal, that would be a high blood pressure for me. So that might indicate that I'm in pain. If somebody's not able to speak and say that they're in pain, sometimes you'll see grimacing where they'll be, making a face that makes them look really uncomfortable, or guarding. If you're doing your assessment and you go to palpate the abdomen and the person flies their hand over to that area, or vice versa, maybe you're doing range of motion on the arm and they have a sore shoulder and they immediately sort of, push your hand away from that shoulder, then that is probably an indication that they're in pain. Withdrawal from activities. So if somebody's inside the hospital, you might see that they don't want to go for walks. They don't want to sit up and, speak with their family. If it's outside of the hospital in a community center, you might see that they, aren't able to engage in work, that they don't want to go to social activities that they used to enjoy. So that's something to look out for if somebody's in pain. So how do we measure pain? So one of the things we want to do is, because, you think pain can be sort of subjective. It's patient reported, right? It's not like a blood pressure where we can measure it and get this very definitive value, that we rely on the patients to tell us what that value is. And so there's something called old cart to remember how to rate pain. So the first thing we want to do is rate the pain 1 to 10. And I like to give people a reference. So I like to say 10 is the worst pain you've ever experienced. You got hit by a truck, or, your arm was severed. One is a sunny day at the beach. So to give them a sort of reference of what you mean by 1 is, very pleasant experience, very almost no pain, and 10 is the worst thing that's ever happened to you. The other thing that's really important is to ask, what is a tolerable level of pain? We find this here is that sometimes people have an unrealistic expectation that after surgery, they're going to feel no pain. And that's just not true. After surgery, you are going to feel some pain, even when medicated. And so we want to find out, what is tolerable to you? Is it a 3 or a 4? By tolerable, we mean you might have some mild discomfort, but you can still get out of bed. You can take good deep breaths. You can participate in physical therapy, because that's really the goal that when we're in the hospital, is we want people to be able to still participate in their activities. But we don't want someone so knocked out from pain medication that they can't participate. So what is a tolerable level of pain for that patient? The next thing we want to know is when did it start? What was the onset? When did the pain start? Where is really important. Where is the location of the pain? Duration. Is it off and on? Is it constant? Describe that. Characteristics. Is it sharp? Is it dull? Is it throbbing? Ask the patient to describe the pain. Aggravating factors, meaning what makes it worse? If it's chest pain, for instance, when I'm sitting still, I have no pain in my chest. When I get up to walk around, it gets worse. Similarly, maybe back pain. When I'm, laying flat, it feels fine. When I try to sit in a chair, it gets a lot worse. Relieving factors. What makes it feel better? Someone with chest pain might say, I feel chest pain. When I sit down in a chair, it gets better. Somebody with back pain might say, when I lay down and elevate my legs, the pain resides. So it's important to figure out what are the aggravating and relieving factors. And finally, what have they tried for treatment? Oftentimes people won't come to the hospital as soon as they have pain. They will have tried a few things for themselves at home. And so that's important information to have. Have they already taken pain medication? Did they already try a salve or a cream? Did they already try hot and cold? What have they tried? And then a focused assessment on the system associated with the pain. So this again goes to that emergency alert system, that we don't want to just mask the pain. We want to find out what's happening. So if somebody's coming in with terrible abdominal pain, we certainly want to treat the pain so that the patient can focus and participate, but we also want to listen to those bowel sounds. We want to ask them about their bowel movements, ask them, you know, about their appetite. We want to listen to the all four quadrants. We might want to palpate around and see if we feel any masses or pulsations. So it's really important that we do a focused assessment on wherever the pain is coming from so that we can treat the underlying cause. So how do we manage pain medically? So you see in bold here, we want to identify the cause of injury because ultimately we want to treat the underlying cause of the pain. Whether it's, you know, a cut or, you know, whether it's chest pain, we want to make sure that we're treating it. And then medications that we might use anti-inflammatories, regular analgesics, narcotics, muscle relaxers, and then atypical antidepressants sometimes are used for, that's more for like a nerve pain. If you have, you know, folks that have had an injury that has left nerve damage, or sometimes folks with diabetes get this like neuropathy pain, that we found that atypical antidepressants can help with that. Physical and occupational therapy are really helpful for pain. You know, I actually have a pretty chronic back issue. I had a torn disc a few years ago, and a lot of nurses, at least, are not great patients. And I was one of those people. And so they referred me to physical therapy, and I didn't necessarily believe that it would work. And it did. It really helped a lot. So physical and occupational therapy can really help with pain management and help with increasing mobility. So nursing intervention. So, you know, it's not just medication, but changing positions. You'll see here, this person has a bolster underneath their legs that sometimes really helps with, you know, back pain. Hot and cold therapy can be really great for pain. Distraction. If we're doing a procedure on someone that we can't medicate right away, I might say, you know, do you like the mountains? Do you like the beach? Tell me about, I often, you know, if it's an older person, I say, how many grandchildren do you have? I, you know, try to tell stories to just distract their mind from it for a little bit. Visualization, you know, again, that, you know, imagine that you're at your favorite vacation place, or you're, you know, at a party with your family, something to bring up a pleasant memory that the person can focus on while there's a painful thing going on. And then obviously medication administration is another reason. So that is, let me just see, that's a short little thing on pain. And then I just have this, I have this case study. So let me move to, there we go. Okay. So you are a nurse caring for Mrs. Z. She's a patient newly admitted to the hospital for shoulder pain. The notes indicate that she's a 70-year-old female admitted for the same pain a few times a year. When you approach the room to assess her, she is smiling and appears calm. Her vital signs are 116, heart rate 116, respiratory rate 20, temperature 98.4, blood pressure 179/96. Can you identify which vital signs are abnormal here, or which vital signs do you think are associated with her pain? Blood pressure, very good. Yep. So let's highlight that information. Any other vital sign that's abnormal? Heart rate. Yep, very good. Yep. So this all sort of goes along with her pain. So how would you accurately measure her pain? What are some of the questions you're going to ask her? Do you want me to, let me see. Yeah, so remember old cart. So first we want to get a rate of the pain, right? So do we want to ask her, what is your pain on a scale of 1 to 10? Yep. And then we want to ask her what feels tolerable for her, because if we see here that she's admitted a few times a year. So this is a person who probably has chronic pain and is having an acute flare-up of this chronic pain. So we want to know what her pain is on a scale of 1 to 10. And we also want to know what feels tolerable for her. You know, like she maybe is a person who's never pain-free, but what is a level of pain that she can go about her regular activities? We want to know about when it started and if there's things that make it feel better or worse, right? And if she's tried any treatment. So after asking these questions, she says that she reports the pain as constant, but that it became worse overnight after she worked all day yesterday. It is a 7 out of 10 now, but it's tolerable when it's a 3. The pain is dull and it's worse with movement and gets better when she rubs it. She used some herbs and a compress that usually work, but it didn't this time. She's not been able to sleep all night. So because of her age too, what are some of the things that she is at risk for? I don't know if we talked about it a little bit, but she's already at risk for a pneumonia because she's older. So we don't want her in pain where she's bracing herself and not able to take good deep breaths. If she's immobile for too long, then she really could lose that mobility long term. So we want to make sure that we get her pain back down to a tolerable level so that we don't lose any more mobility or cause her to have complications. What nonverbal data supports the patient's report of pain? Do you remember how we look at pain if somebody isn't able to talk? Grimacing. Yeah, or guarding. Maybe if you go to do a range of motion on that shoulder and she's like, bats your hand away. Remember, she said that moving it made it worse. So that would be nonverbal cues that would tell you more about the pain. We talked about this a little bit. What complications are you concerned with if Mrs. Z's pain is not properly controlled?
Depression.
Yeah.
Mhm.
Yep. Depression, anxiety. She might withdraw from her family.
Increase activities.
Exactly.
Yeah.
Very good. Very good. So besides pain medication, what other interventions can you use to help Mrs. Z's pain?
Recreational therapy.
Yeah. Very good. Yep. Physical therapy. Anything else?
Sometimes can you position it?
Yep. Very good. Yep. Maybe even hot or cold therapy. Maybe a heat pack or an ice pack might help too. Very good. What are some of the side effects of narcotic pain medications that are especially concerning with Mrs. Z's age group? I don't know that we talked about this at all, but do you know any of the side effects of narcotic pain medication? So one of them is constipation. Confusion. Very good. Excellent.
Some can also call constipation.
Constipation, confusion. Very good. Very good. What was that? Okay. Yeah, so what are some of the things that we can do to prevent that? So if we're prescribing pain medication to someone in this age group, we might want to tell her daughter to keep an eye out for the confusion. For constipation, we might ask her, either send her with a stool softener or tell her to make sure that she, drinks enough fluids and has enough greens or fiber in her diet to make sure that that doesn't become one of the complications. So Mrs. Z is treated with hot and cold therapy and self-massage. She's prescribed oxycodone 5 milligrams every 6 hours as needed for severe pain. Mrs. Z is discharged home with her daughter. So we were able to treat her, it looks like, with some non-pharmacological therapy, as well as some narcotic pain medication. All right. Any questions about any of that?
Yes. I don't know whether you did that in your presentation because I went out a bit. So I want to know if the pain scale is being graded by the patient themselves or the nurse.
The pain scale. Okay. So the pain scale is being created by the patient. So we're asking the patient, what is your pain on a scale of 1 to 10? And we're telling them 10 is the worst pain you've ever experienced, and 1 is like a pleasant day. And so you're asking them to tell them where it is on that scale. That's a great.
So in case of patient that is unconscious, so how do we go about it?
Very good. Yeah, let me share my screen right here again so you can see. I don't think I pointed this out, but here there's a nonverbal pain scale. So you can look, and so you can see the patient's face and sort of scale it yourself based on the patient's face, because it's true, like if somebody's nonverbal and they're constantly grimacing, or they like visually look crunched up and uncomfortable, then you can score them, versus if somebody's like smiling and relaxed and in bed but they're not able to talk, then it's, you know, pretty much a 0. The other thing you can look at is those vital signs. That's another way that you can tell if somebody is in pain. If yesterday their heart rate was normal and their blood pressure was normal, and now everything's very elevated and you're seeing a face like this, then it's pretty reasonable to assume that they may be in pain. That's a great question. Any other questions?
So the other contribution is we can also do a glaucoma scale for us to know the if the patient is in pain, right? So what I'm trying to say, in case you do that glaucoma scale, then you find out that you cannot notice any pain. Is it that the brain is not functioning? Because I come to realize that based on the types of pain you are feeling, whether it's a damage to the tissue, whether it's an emotional, it has to do something with the brain. So in case maybe, because what I'm saying is some people can get wound without knowing they have a cut on them, except because that had happened to me when I was a kid. You know, I had a wound unknowing to me. So my friend happened to me, like, my guy, you have a wound. You know, that was the time I started now experiencing the pain, because I have now my, you know, idea over what is happening with me. Sure. So I'm just trying to say, how does that relate to the central nervous system?
Yeah, so what probably happened to you was that you are in shock. Your brain, so it's human beings. I mean, I could actually talk about this for hours. Human beings don't like to experience pain. So a lot of times we will do things to avoid pain. And so your brain will sometimes decide, if the pain is too great that your brain thinks you cannot handle it, it will sort of cut off that communication from the peripheral nervous system to the central nervous system. You will see this, you see this, you know, in military, sometimes in war, that somebody's like running away with only, you know, one arm or something. And it's because the brain has basically put a block between the peripheral nervous system that has the message, hey, there's this injury, and the brain who can register it. So when you were a child, maybe that wound was like so painful that your brain didn't let you feel the pain in order to not harm yourself. The other thing that can happen is if there is like a chronic injury. We see this in spinal cord injury. So if somebody's had a spinal cord injury, that the spinal cord really is the messaging system between the peripheral nervous system and the central nervous system. So if somebody's been in a car accident, or they've had a penetrating injury that damages the spinal cord, then you can also have an injury anywhere, and it doesn't allow the message to go to the brain, the central nervous system, to receive that information. Does that make sense? Okay. I wanted to make sure I answered your question. Great.
You know, Nicole, too, another point that I remember, you know, studying was the cranial nerves. And so it's the cranial nerves, I believe it's the facial cranial nerve and the trigeminal cranial nerve that regulate our ability to grimace and to frown. And so if there is an injury to a cranial nerve because of a brain injury or some sort of swelling or other, you know, pathologies that can impact the cranial nerves, a person might not be able to physically show us the grimace or show us the lack of smile. So we have to be thoughtful of our entire assessment And I would draw your attention to paying attention to anyone with some sort of neurological process, whether or not those cranial nerves are intact.
Yep, that's a great point too. Yeah. It gets tricky, right? If somebody can't tell you that they are in pain, then you really have to rely on the vital signs and objective data to be able to assess whether or not the person's in pain. Yep. Great questions. Smart group. Any other points?
Hello, good afternoon.
Hello.
I want to know the pain management scale with reference to the pain rating scale, because I want to believe we have different category of pain and we have a different pain medications that require the different stages of pain that patients experience. So I want to know the pain management scale.
Oh, the pain management scale. So it really, so you're saying that you have like, if their pain is this, then they receive this medication. Is that what you're saying? Yeah. So we do have similar things, but it depends on the patient. So it's not necessarily a set thing for every single patient. There are similarities, like in surgical pain, we often use oxycodone. More and more, we're trying to get away from narcotics. And so more and more you're seeing pain scales with just like ibuprofen or, Motrin and an NSAID or an anti-inflammatory versus going right to narcotic pain. But it's true that we will have, if the pain is between, 7 and 10, give 10 milligrams of oxycodone. If it's between 4 and 6, give 5 milligrams. And if it's between, 3 and 6, then try, Tylenol or hot and cold or some non-pharmacological intervention. Does that make sense? Yeah.
Thank you.
But it's not set in stone, because we have to consider kidney function, and we have to consider body mass, and we have to consider history of substance use. And so many factors come